Sorry about that. We were having just a few tech issues, as per usual, it seems. So we are going to let folks flow in. We are going to get started pretty quickly here because we've got a packed agenda today. I know folks are really excited to get into the topics. While folks are flowing in, I'm going to just do some quick housekeeping. My name is Cassie Westmoreland, she, her pronouns. I've got Rebecca Mayer here as well as Carolyn Taylor from the SHG Advisors team. And we're joined today with a lot of really exciting presenters. So I'm going to be talking. You're seeing my screen here. Rebecca is going to be keeping her eye on the chat box. You are going to be muted upon your entry. So please feel free to add your questions, anything as we're going through to the chat. We're going to try and create some space for our presenters to answer your questions in real time because we know a lot of you who have been doing the Lift Academy with us for the last 6 months or so have a lot of questions about how to engage with emergency response. So we're excited to do that. Last quick housekeeping thing. This is being recorded. This is being transcribed. We're going to add all of this to our SHG Advisors Lift Academy website, which hopefully you all have seen. But do just want to flag that it is being recorded. So, quick highlight of today's schedule. Welcome. Thank you for being here. For those of you who are here in real time, as well as those of you who are here on the recording. Like I said, we're going to talk about where homelessness and emergency systems overlap. So, we're seeing a lot of really interesting trends in Colorado of homelessness being pushed more and sort of into emergency response systems. A lot of our emergency response systems are being asked to deal with homelessness. We've had a lot of questions from the folks who are participating in the Lift Academy about how to better engage with those systems and do proactive crisis and de-escalation as opposed to reactive crisis response. So we've got presenters from police departments who are very well equipped with co-response models. We've got a local provider, Loaves and Fishes, who's here today to talk about reentry and in-reach into jails, as well as some co-response support. And then we've got some consultants who are working nationally with healthcare ecosystems around how to better engage and create return on investment for everyone involved. Like I said, we are going to have some time for Q&A at the end, hopefully, which is why I'm pushing us through here quickly. But as I said before, any questions that are coming in, please, Rebecca's going to be monitoring the chat as we go along. Even if you have a question, from the first presenter and we're on the third presenter, put them in the chat. If we don't have a chance to answer them in real time, we will get you all the answers. So just really quickly, I'm going to go over who's presenting today. At the beginning of each presentation, I'll give the folks from these organizations an opportunity to introduce themselves, tell a little bit about their background, what they bring to this work. But at a high level, we've got some folks from the city of Aspen, the Aspen Police Department, who are doing some really great work around co-response, creating human service officer model. We've got folks from Loaves and Fishes. They're the ones who are going to be talking about a little bit of a co-response model as well as in reach into jails. So going into jails to deal with folks who are experiencing homelessness, they have a plan on their way out of the jails. And then Forward Slash is our group who's focusing on healthcare ecosystems and really wanting to make sure that we're working as collaboratively as we can with those populations. So we're going to get started. I'm talking really fast, but I want to make sure we get into the meat of this. So Rebecca, just interrupt me if there are ever any questions or anything in the chat. But we're going to get started with Braulio Jerez, who is the Human Services Officer with the Aspen Police Department. We've got some very specific questions for Braulio. But before I jump into those, Braulio, do you mind introducing yourself, telling us a little bit about your job and how you came into this work?
Sure. Thank you, Cassie. Good morning, everyone. My name is Braulio Jerez. I am a police officer with the Aspen Police Department. I am the Human Services Officer for our department. We've had roughly 4 iterations of Human Services officers for our department. I am the second iteration. We've had two others that came after me that didn't last that long, but I've been the human service officer consistently since 2019. The city of Aspen and the Aspen Police Department has been pretty progressive in approaching our social welfare issues that exist in our communities, even prior to the large influx of disgruntled individuals around law enforcement, pre-George Floyd and post-George Floyd. So I think we definitely have the ability and the opportunity to engage with folks in our community on the ground level. So our program has existed since 2017, roughly, but like I said, I've worked since 2019 as the human service officer and worked with co-responders since that time as well.
Thanks, Braulio. And these questions really do represent the questions that we've been getting from the folks that are doing this work on the homeless response side. So what we're really hoping to ask and hear your experience around today is what are the most common areas of overlap between people experiencing homelessness and the police? And what are those things that you feel like police are being asked to do that maybe you are least equipped to do? And AKA, what are the win-win scenarios that homeless service providers can use in their communities to bring law enforcement to the table, or help law enforcement do what they're asked to do every day?
That's a great question. So I think over the years, and it's probably always existed, um, law enforcement is the first responder, the first response to any active emergency, or not even an active emergency, it could be anything. You always call 911. So we've become the social worker as officers over the years. Thankfully, our country has become more progressive in understanding that these issues are beyond just, criminal actions. There's mental health, there's substance abuse, there's a plethora of other issues, housing that we come across on a daily basis. So I think that shift in mindset that has happened nationwide has created programs like mine and co-response models that exist. Um, and our training, I think officers these days have more elaborate, more uh, I guess I don't like to use the word aggressive, but more training in verbal de-escalation, in mental health first aid, in CIT, that's crisis intervention training. I mean, all these types of training that are offered to officers and are at some point at some time during their career required for officers have given us the ability to engage with folks that are experiencing a various of different issues on any given basis. So I think the win-wins I would say would be like the housing first models. We know that because of Maslow's hierarchy. You house somebody, you feed somebody, you provide these human resources and options. Typically, you have the individual. You know, I feel like they'll be more successful in engaging. Does that answer the question?
Yeah, and it leads me to the next one. Um, a lot of your calls, sort of anecdotally, this is not necessarily you with the city of Aspen, but broadly, we're hearing from police that a lot of calls are originating in some way because of that lack of stable housing as you go back to the Maslow's hierarchy of needs, right? What are those pain points that your department feels because of that? And I think what I'm trying to get at is like, what can our homeless service providers take to their local police and say, "Hey, we know this is a pain point. Let us help you solve this issue," right? Like what can we do to sort of, I don't want to say sweeten the pot, but incentivize them to come to the table?
Yeah, I think the best option is to go directly with those agencies, those first responders, those that are being impacted in some capacity with these type of calls that are related to either homelessness or whatever may pop up. Um, there's always like this fear or stigma behind engaging with local law enforcement because of what law enforcement has to do at times is, make that arrest when you're working with a client, let's say. But there are ways to let's say have that situation happen and also offer a resource on top of that. So when that's what the correspondent models are great because you show up on scene on an arrest. Let's say, and you're also offering that resource. Like, hey, you can, if you need some mental health support, some housing support, some substance abuse support, we have those options. But you have to be on the ground with law enforcement. I think that partnership is ideal and is what we've seen works. To be on the ground, boots on the ground, and engaging at the time of the incident or even the follow-up after. But nonetheless, there has to be a connection point. There has to be a point where folks are connecting, these nonprofits, these advocacy groups are connecting on the ground level. Um, I think, you also talking about get getting in contact with local law enforcement and that stigma, it's hard to bring people in to the family, the law enforcement family. Um, we happen to be really really happy and really proud of having our partners live with us in our offices and respond with us on scene for the three agencies that our responder model works with, which is Pickens County, Snowmass Police Department, and Aspen Police Department. Um, we have been very receptive and are comfortable receiving, but I know that is not going to work everywhere. The the more you hassle and haggle them to bring you in, the better it's going to be. It's hard, it takes time to build that comfort and that relationship with these entities, but it can be done if they see that you're offering something that they can use. Anytime anything that they can take off their plate and off their shoulders, they're going to be willing to engage in. But you have to offer it and say, this is what we can do on scene, after hours, follow-ups. This is what we have. This is a resource that exists. Here's this. Please call us. Please contact us. Have us show up.
Well, it's like we planned this, Braulio. What are some common overlaps between homeless response and police response, and where do those points of interaction naturally exist in your experience?
I think, uh, the most common is that when we get those calls for the frequent flyer, the high utilizer, and the impact on these resources. On the first responder side, you have a fire, ambulance, hospitals, law enforcement, the community as a whole. These are the common points where that is being addressed and where it's I guess it's draining that resource. It's impacting that resource. It's impacting the community. The call you try to be proactive, and we try to be very proactive when we are out and about in our jobs, doing our jobs. But sometimes that call comes in from a concerned citizen. There's a person laying in a park. Sometimes it's very reactive. They're just not used to seeing it, especially in a place like Aspen, where affluence it's up there, and you don't expect to have homelessness, but we have a cadre of folks, about 35 to 40. I forgot the last point in time count, but we have a substantial number of unhoused folks, and how that's classified in our communities. And we have to find a way to engage um, as much as we can and be proactive, not always reactive. So by having boots on the ground and having programs like a human service officer, which has different iterations and different names around the country, co-response, these are ways to approach that and broach that. The peer programs, the navigator or street outreach programs with homeless services are huge. Case management, if your program has that. Huge. It's just that extra level of support that you can offer the individual, the client, and the agencies that you're working alongside.
Mm. And I think one of the interesting things we've heard, you mentioned that it's kind of surprising for folks in Aspen to see people experiencing homelessness even in some of our like less affluent rural communities. I think that's a similar conversation, different reasons, but
Mhm.
similar surprise. Like, oh, we have homelessness? That's never happened before. What does that look like? And, folks in the know are kind of like, oh no, we know these folks, but they're showing up in ways that they might not have been in the past. So thinking about that, and you've spoken about this a little bit, and I know it's going to look different in every community, but how do our providers build that handoff between law enforcement to service providers? And what can that look like in real time?
I think they're, having an accessible number, having a referral resource. We use a referral resource called Gelada, which we officers that are contacting folks after hours when our correspondents are not available, can, put a narrative into this referral resource and have the HSO and the co-responder follow up the next day after the weekend, whatever it may be, depending on the scheduling. So I think that's one way to have that effective handoff. The having a local phone number. Hey, we're in contact with Joe Smith. I know you work with Joe Smith. He's displaying, or he's saying that he needs help with this, this. Having access to an individual that we can either bring to a location or have those navigators, those street outreach folks, those case managers, those peers show up on scene. That would be the most effective way to do a handoff, just, face to face, one on one. I know that doesn't always work because of resources. We are in a rural community, even though there's affluence in Pickens County and money is up here. It doesn't mean that those services are provided to these folks in our community. So, what can you do? What resource exists? Knowing all your resources, having printouts of these resources for folks, bringing in flyers to local agencies. I think sh showing up in a way that you are willing to engage and provide an access point is the best way to do that handoff, to exist within that environment where you're offering that resource. So a warm handoff is always the best way to do it, especially when that resource exists. I know that doesn't always work in all communities, but try to find a way to navigate that. You have to become creative. Honestly, I think that's something that we take a lot of pride in. That when the resource doesn't exist at that time, that hour, that during that situation or that incident, we try to become creative on how to get this person the help and the services that they need. It doesn't always work out, and that sucks. But that, if it's not life-threatening at that time, there is a way to provide that service at some point. Hopefully sooner rather than later.
Yeah. And I think I've seen a couple comments come in, so I'm going to ask one last question, then we can open it up to some of the questions in the comments. And again, you've spoke on this a little bit, but where do people start? For our folks that don't have a good relationship with their police, who do they go to? How do they start being that squeaky wheel?
I think knowing what health services are being provided by your community. So community mental health services are one access points. The actual county administrators for these health programs are one possibility. A municipality like City Hall or that municipality contacting those folks and like, hey, we are this service. We want to provide, we want to engage with our local law enforcement. We're having some issues, getting, acquainted with and having friends in other places maybe would be the way, the introduction, that olive branch that you need to get the the support that you want to offer or give. Because, like I said, there's going to be some resistance. These programs, cops didn't sign up to be social workers, unfortunately. So for some reason, I did. Even though I have no degree, I do love the work that I do, and I love providing this degree of help and services for our community. But I'm very passionate about it, and I appreciate it. My department offers and allows me to pretty much figure things out and create programs locally. I mean, they paid for my substance abuse the CAT um, certified addiction counselor or technician course while on duty, which I did in 2022 because I didn't have a background in substance abuse. So how do I understand the individual that is in front of me when I truly don't understand that aspect of that person's life? Well, I needed the education, and it has benefited me, moving forward.
Thank you. Yeah, that's great. And Rebecca, I think we did have a couple of questions for Braulio come through the chat.
We did, and this is from Tim. Do any communities out there, having trouble scrolling, do any communities out there activate emergency response protocols for sheltering like they would for fire or flood during severe weather emergencies? And
Yes.
yeah.
Oh, and finish that. Sorry.
No, no worries. I was just going to say, thank you. I see Dee Dee's also answered, and if other participants want to throw answers in the chat as well from their communities, that's great. But over to you, Rob.
Yeah, I think we have our local homeless shelter or it's called the Resilience Center or the Winter Overnight Shelter by Recovery Resources. They're the company, the nonprofit that provides that service here locally in Pickens County. They have a threshold, which is, I think, the freezing temperature, which is 32 degrees. What we struggle with here is that we don't have enough beds or personnel to man those. So our local overnight shelter holds 12 people, in cots in a room at the Health and Human Services building. That's our only access point. At that location, there also exists the detox, which holds four people, two males, two female beds. Um, but beyond that, once we run out of that space, and we can't fill that resource, we don't have that resource. What are our options? And they're very limited. The hospital, maybe, depending on the situation. If someone is experiencing frostbite, it has to be an emergency. But beyond that 12 bed option that we have here locally, we don't have another one, unfortunately.
Any other questions come through the chat for Braulio? I know we are right at the time when you need to hop off, so we've got like 3 minutes if other folks have questions. But
I don't see any other questions in the chat.
okay, awesome. Then I'm going to ask you my favorite treat cheesy question.
Uh,
Braulio, wave your magic wand. What does police response and homeless service response look like in a perfect world?
a unified response, where we're both uh, at that threshold, at that door, providing that support to have a brick and mortar location where we can bring folks for those services and resources. Again, all these services and resources are voluntary. So when we have that high utilizer, when we have that individual that is opting out of that system for whatever reason, you're stuck between a rock and a hard place there. Trying to provide a service, but their unwillingness to take that. So ideally, in that that world where I can wave that magic wand is to have all the resources and also have the folks that we're engaging with willing to engage in those resources.
Hmm. Awesome. Well, thank you for the time. We appreciate it. As we have other questions come through, we will make sure to share them with you and get them answered. But in the meantime, I'm gonna head over to our next presenters. But Braulio, thank you. Thank you for the time. And if you do need to hop off, just let
You're
me
very welcome. Any questions that come my way, feel free to email. My email should be somewhere on there, and I can share my experiences with the programming that we have up here.
Awesome. Thank you so much. All right, now we are moving over to Danette and Tim with Loaves and Fishes. And I am going to just let you all take it away. Do you want to do a quick audio test?
Can you hear us now?
Yes, we can. Thank you. And if you want to just say next slide and I'll move forward that way.
Okay, wonderful. Thank you. Good morning, all. Sorry for the delay this morning and technical difficulties. Yeah, so I'm Danette Love. I do coordinated entry here at Loaves and Fishes.
And I'm Tim McFarland, and I do outreach, the outreach director in Fremont County. So a lot of good overlap here.
Yeah, absolutely. So we just kind of wanted to share our experience with co-response and jail-based behavioral services that we work with. Obviously, outreach has done a beautiful job in building that relationship with our JBBS and our co-response team, as well as BLM. We work really well with all of them. They're lots of meetings with them. And so kind of some of the things at Loaves and Fishes that we believe that no one should have to navigate their hardest moments alone. And I feel like that is the community in a whole. if it's a neighbor is currently incarcerated or facing a mental health crisis on the street, we meet them exactly where they are as a team. So by partnering closely with our local co-response team and our jail-based behavioral services coordinators, we combine clinical expertise with a simple human promise. We won't let you fail, or we won't let you fall through the cracks. Next slide, please. So we kind of wanted to share just a couple stories with you all, and kind of the support that we do while we're in the midst of that storm. So when a mental health or substance use crisis hits, our partnership with the co-response teams ensure the answer is care, not just handcuffs. So we step into we step in and stabilize the situation and protect the dignity of our neighbors. There's case study preserving belongings. So kind of one of our stories that we wanted to share was one of our elderly that was housed was struggling with dementia. Police were called. There was, not paying rent. And we knew that she was going to be kind of in trouble. And so co-response was on top of it. She reached out to outreach. Our outreach team reached out to everyone in the office, and we were able to kind of go and help her. She was taken away for a moment, but our wages program, outreach, myself, and everyone else who was available inside Loaves and Fishes in the community were able to get her a shelter. We were able to put her belongings in storage while we got contact with a family member, and were able to get her to a facility that worked well with her. So instead of escalating the situation and incarcerating her, and she's already going through all of this trauma, she wasn't from this country, she was really just didn't know and was scared. So we all just kind of pitched in as a team and helped out the situation. So just really proud of moments like that. Another instance was we had a psychotic break with one of our unhoused individuals, was just kind of in the middle of our busy street and was just wanting to kind of end his life and yelling and screaming. And again, co-response was able to engage with him, was able to get him over here to the shelter. We were able to work together, have a stable, safe place for him to be, where he didn't feel judged, where he was really struggling and just kind of all over the place. But we were able to get him off the streets, get him over to the shelter, and then outreach, the shelter, myself, and co-response were able to work together and get him to another facility that worked well for him to get him the treatment that he really needed. So we're really just proud of that. We're proud of those relationships that we build with them. Another instance, next slide, please.
Can I ask you can you define wages just for what some folks who might not know what the wages program is or does?
Yeah, so our wages program is they work with individuals that are coming out of jail.
Awesome.
Dee Dee,
Thanks.
elaborate a little more on that.
Did you say, do you want me to elaborate more on that?
No, I was saying it because I know Dee Dee's on the call.
Yeah.
More of the wages program and kind of how all of that works.
Yeah.
Oh,
Dee Dee, we can't hear you. Sorry. Loaves and Fishes does not like our Zoom. We
Yeah.
will come back. Sorry about that.
we roll today.
Okay.
Yeah, but it's just another program that's within Loaves and Fishes. And again, they work with parolees that are coming out of jail and prison and getting them housed. And I believe they work with them for up to a year. So another great program. And we are always working with her guys or gals that are coming from her program. They come over, they volunteer, they work with us. They are a huge part of the community. A lot of the officers that are have arrested some of these individuals, are seeing that they're out there, that they're helping, that they have that love and compassion. So again, it's a beautiful thing. We had all of these men come from this program and help us literally within a few hours. We were able to get all of the woman's belongings that was a lot into a storage unit. So it's just beautiful to see those relationships and kind of see the police being able to see the people that they've had maybe a bad encounter with be able to work together and really see the community thrive. So
I was trying to look at Dee Dee's comment and it messed up my screen share. So bear with me for 1 second now while I go back into this. Give me 1 second. Okay, share and there we go. All right. Can I get a nod, Tim and Danette? Can you see my screen now?
yes.
Yeah, okay, great. All right, next slide. There we go. No, here we go.
Okay, so the biggest thing for us is just starting that conversation early. We don't want to wait for someone to be released to start helping. So we can either go into the jail and meet with somebody. We can set an appointment. Again, our JBBS. Am I saying that right?
JBBS.
Yeah. We work with her. Her name is Yvonne. She's wonderful to work with. I can call her up and say, hey, can I make an appointment? I know that this individual is in jail. Want to be able to kind of come in and assess them, get a VI SPDAT, and we can go further. You can get extra training so that you're able to not be in the glass per se. But that is really helpful because it builds a plan from day one. When we know that that person is incarcerated, we can go in and kind of see where they are, what their goals are. We had a youth that I was working with, her dad that was recently incarcerated, was able to go in the day that, well, a couple days into her being jailed, was able to get right in, talk to her, get an assessment done on her, work on some goals with her and see kind of, just where you're at, get her housed once she's out and just support the people that are coming out of the jail. So just building that bridge with them, transitioning them back into society it's a lot, right? So we try to just work hand in hand with everyone in our community to be able to, have, again, that warm handoff. Coming out of jail or a mental facility is hard. And so we just want them to know that we're here, that we support them, that, that warm handoff is available, that, with a lot of work and with a lot of conversations, we can really build that.
Yeah, and another part of reaching out to folks that are in jail, early on. We're in 2026 now. We're in the age of technology. So NCIC is something that I've utilized a lot fairly recently to be able to do a remote visit with somebody. So the way that our county works, and NCIC they contract with a bunch of places across the country, but specifically I've used it here in Fremont County. But you can schedule a remote visit with somebody, and they get a tablet in the jail, and they can actually have that conversation with you. You're kind of having that face-to-face conversation, but in the age of technology, we're all glued to our computers, including literally right now, and our phones and everything else. It kind of works. We're all human, and meeting them where they're at, that's a big part of it. So doing that kind of visit has a little bit of a different impact in the sense that you're kind of meeting them where they are at, whether it's sitting down in a chair or in their bed in the jail. And that what I've noticed in doing that, especially recently, is you get a little bit more of the raw conversations. You kind of you gain that trust a little bit more, and you can kind of have a space where they kind of open up about a lot more. You kind of learn about a lot more within a shorter time frame. So having these 30-minute visits or however long it is on the remote call, where it's like, all right, well, how are you doing? What is going on in your head right now, especially since you first kind of got in there? And then the second half of that 30 minutes can be, all right, well, what's your plan when you do get out? We actually have somebody that's actually getting out this Friday. It's somebody that we've all worked with actually very recently, but she actually called ahead of time and is coming directly to our shelter for this weekend, straight from the jail. And it's that interaction, that meaningful impact of meeting them where they're at inside that jail, that seems to be, pushing her towards the direction of improving and getting more stability, things, continuing the work that we have been working with this individual with. And I think that's just incredibly important and valuable to be able to meet them where they're at in the age of technology too. So that way we don't have to go over to the jail necessarily. You can just kind of, meet them where they're at. They'll get notified, they'll get handed a tablet. And then as soon as that time's up, they come and grab the tablet from the individual. And, I think that that's just something I wanted to make sure to share is it's, I guess, a newer technology, of course, but it is something that I found to be very valuable in gaining that trust and heading towards those next steps.
Yeah. I have a question. I'm going to do a quick pause to see if we have any questions in the chat as well. But what are the logistics of finding that person? Like this person who's being released on Friday, like how did you identify this person and get connected initially? What does that look like? I see a laugh. I'm sure it's different every time, but go ahead.
Yeah, so with coordinated entry, that's kind of my job to keep track where and outreach, So again, partnering with our local authorities, they'll either let us know. But again, I'm constantly looking, probably daily, weekly, of where are our individuals. So I use VineLink and a couple other pages to kind of check in on everyone, and if I haven't heard from them in a week or so and Tim hasn't, then that's something that we use as VineLink to see, have they been arrested? Are they, where are they at? What are the charges? So we're kind of constantly checking those bases too, those databases that tell us, if our unhoused is in jail. So yeah, that's one of the ways or a couple of the ways that we use. Again, the co-response, she's great about letting us know, and really the community.
Yeah, I was going to say in outreach specifically, a lot of people just talk to each other. And so sometimes, if I'm checking in on one person and that trust is already there and developed with that person, they'll be like, hey, did you hear that so and so is in jail? And then it just kind of, triggers. And then, of course, I'll reach out to the coordinated entry and say, update every piece of information, figure out where they're at, how long they're there, what the charges are, and kind of learn as much as I can, even before we make that initial contact, just so we can go in prepared ahead of time as well. But yeah, there's just a lot of, like Danette said, there's a lot of ways that we kind of track that down. But the community, once you gain that sense of trust in the community, that word of mouth is very valuable. And it means a lot that the community kind of looks out for each other in that sense too. So yeah.
Rebecca, did we have any questions or anything in the chat?
I don't see any in the chat, no.
Okay. Great. Well, I'll go to the next slide. I have a few more, but I'll let you all finish your presentation.
Take your slide.
Oh, sorry. So just kind of the last, we're just trying to break the cycle. Our goal is simple but vital to ensure that the exit from jail cells or a crisis center doesn't lead straight back to the sidewalk. By building deep roots of our justice and behavioral health partners, we create a safety net of housing, sobriety, and community. We aren't just managing cases, we're helping our neighbors find their way back to themselves. And I think that's the one beautiful thing about Fremont County is there's just a huge heart. Everyone is just so gracious and steps in, if it's even the unhoused and everyone, we all have kind of the same goal. We just want to meet people right where they are, and build that trust and build that community and just love them right where they are and walk alongside them. It's sometimes that means the world. And that's important to us.
Yeah.
Yeah.
That's amazing. Thank you for that detail and some of those tips about the data and using technology and all of that great stuff. For folks that are not as robust as Fremont, so for people in the presentation who don't know, Fremont has a wonderfully robust coordinated entry system, kind of getting national attention. Kudos for that system. For folks who are just getting started, who might not have ever heard of jail-based behavioral services before or WAGES before. What are some tips and tricks? What are some lessons learned that you might share to set up those relationships and sort of start that infrastructure that you all have been able to grow?
Meetings, starting the conversation. not being afraid to go into the jail and asking, what services do you provide? How can we work together? What can we do? Going to, if your community has town hall meetings, if there's, just being aware and putting the word out there and,
Yeah, I would agree with that. Just I mean, lots of communication.
yeah,
That's a very big thing. It's whether it's community partners in the jail themselves, whether it's the officers involved, whether it's mental health providers.
yeah,
Everybody plays their role, and as long as there's a good sense of communication between everybody, um, it kind of makes it, on a good track or an easy track. There's a good path to follow, right? And so I know we have it set up to where if a specific situation happens, we know who to reach out to, and if we don't, we know who will find out who to reach out to. Um, yeah. Going on, oh yes, and then going along with law enforcement on ride-alongs. Thank you, Dee Dee. Yeah, so I've done ride-alongs with city, county, and federal, so BLM land, BLM officers, and getting that sense of how they treat the community as well. It's a partnership, but also a sense where you get to understand how law enforcement officers of varying levels speak and interact with the community, and they also learn from our interactions as well with the homeless, because there's a big difference with showing up with a badge versus showing up in the loaves of fish's vehicle. But understanding that dynamic from the beginning is important. So working with those officers, and then also site cleanups as well. So you know, ways that we contribute kind of back to the community is, you know, any sites that have been abandoned that are around the community. They kind of can be an eyesore. They can be, um, things that are just, they need to be cleaned up. But we work with individuals that are the unhoused that would like to actually volunteer and go contribute back to the community. So it's kind of like a recycling system almost. And that shows good faith in the community. That shows, uh, putting forth effort, and it shows that people that we have helped before want to contribute to the good cause. And so that's where, even site cleanups on federal land, we can go out and help that out. So it's kind of a give, a sharing relationship with all of this. Yeah, hopefully that's helpful there.
I think so. Kind of reminds me of what Braulio was saying about, just get started, be the squeaky wheel, be the reminder that, hey, we're here, but adding that layer, Tim and Danette, of like, well, we're not just here because we need something. We're here to help. We're here to work together. We're here to, make the community a better place.
Absolutely.
how can we all work together? We're here, we're going to keep showing up, we're going to keep expressing, whatever it is, service, so that we can all continue to work together. So, yeah.
And Rebecca, anything else that came up in the chat? I saw the little notification, but that might have just been Dee Dee's
Yeah,
comments.
Dee Dee added a couple of notes that Jeanette and Tim were able to expand on, but no other questions yet.
Well, thank you, Dee Dee. Sorry for the tech issues. I don't know why Loaves and Fishes tech doesn't like our Zoom, but I think it's our Zoom. I don't think it's your tech for what it's worth. Um, Okay, well, thank you both so much. We are gonna move to our next group of presenters. Although if anything else does come up, please feel free to put questions in the chat, as I've said before. So we are really excited to have Forward Slash here. They have done a lot of work nationally, so not just in Colorado communities, but looking at engaging with healthcare ecosystems sort of broadly. And I'm gonna stop sharing. I only have one headshot, but there's a few of you all here. So I apologize to the others. Who I don't have their headshot here, but yeah, I think Samir, Andrew, and Josh from Forward Slash are going to take it over now.
Awesome. Thank you for the introduction, Cassie, and thanks for having us. And very cool to hear everyone's story, and thanks all for the presenters for being here as well, and all the audience members here. So you can all see my screen, is that right? Awesome. Technology works. Okay, so yeah, Forward Slash is a national organization. We're in about 5 states, West Virginia, Kentucky, Washington, California, North Carolina, and our goal is to solve homelessness, not manage it, as I think is often the phrasing. But we kind of work with the premise that so much beautiful work, case in point, this presentation of the last two presenters, is happening in communities. It's affecting health outcomes. It's reducing hospital and emergency use. It's driving value, but it's happening by folks that are like yourselves in the community, doing this work via nonprofits and because it's the right thing to do. And so it's really disconnected from the healthcare ecosystem that sees these folks in the emergency rooms and paying from it from a Medicaid standpoint. I mean, really, we're really here to bridge that gap. So this might get technical at times, and please feel free to interrupt, ask questions. We have my teammates Josh and Andrew in the chat as well or on this call, and they can answer questions in the background. So please don't be shy. Our team here, so starting with myself, my name is Samir. I'm a family medicine physician, actually, still in practice. I live in Nashville, Tennessee, but I've practiced kind of all over, largely with marginalized populations, tribal, special needs, homelessness here with forward slash. And really this stems from just a lot of frustration being a physician and seeing folks experiencing homelessness come through the ER and night after night, they might claim chest pain or something, but of course all tests are negative, and ultimately what they want is a safe place to stay, a warm blanket and a sandwich, and that happens in our country in every community night after night, over and over again. And we're not addressing, or I couldn't address the root cause as a physician. Our nurses, doctors, great folks, but not actually getting at the root cause. You guys are. It's housing, it's services, it's in reach, it's social work on the streets. That's actually doing it. So our goal here is to bring in a group of folks across different industries. We have finance, housing, housing development, technology, public health, policy, clinicians here just to bring that sort of expertise to the communities and really bridge that gap, like I mentioned. You all know the stats here. I don't have to belabor this too much, but homelessness is increasing, housing insecurity, housing shortfalls, all increasing in 2026 America, and it just shouldn't be, shouldn't have been for a long, long time or ever really. But here we are, and as it increases, as we've seen with the point in time counts year over year, there is an according spend from a healthcare standpoint that comes with that. So as homelessness increases, there's more emergency use, hospitalization, psychiatric hospitalization, most of which is actually inappropriate. It's not that these folks are sick, like I mentioned, it's just that there's nowhere else to go. There is no primary care, or it's just some food for the night. So costs here that we're seeing from a health cost standpoint exceed $25,000 per person per year. We've seen as high as 100 plus thousand dollars per person per year. There's been some studies of, folks going to the ER 200 to 300 times per year, costing the state millions of dollars. And all of this is the work you guys are doing to avoid these costs and reduce this spend. But as these numbers increase and as these costs mount, these pressures are felt by all the healthcare ecosystem stakeholders, hospitals, health insurers, state Medicaid, cities, counties, et cetera. And so this is where the opportunity lies, where it's an opportunity for, as states and all these groups feel these pressures, they're starting to incentivize the actual coverage of things like housing and housing services, and specifically organizations like yourself to be involved and be the ones to actually do that work and finally get paid for it. So we work with organizations across the country to do just this, and we help, negotiate the Medicaid contracts, have the hospital conversations. But really, this starts with you guys actually understanding kind of the how to start to work with healthcare. So we're going to review about 4 steps here, try to break this down as simply as we can. Again, might get technical. Please ask questions. Please pause me if I need to repeat anything. Might be some acronyms as well, and I apologize. But okay, so starting with a healthcare landscape scan. Again, this is understanding what your healthcare environment is, who's around, what each of them need, what are their priority areas, what's being released in RFPs. The second part here is the health and housing alignment. So any of you who might be COCs under HUD and have access to housing subsidies, how can those subsidies map to potentially Medicaid members or folks coming out of the hospital, what local providers and partnerships are there across other social determinants of health needs or other housing needs as well. And then sort of the data piece here is an interesting one. I think the barriers to working with healthcare include, yes, contract mechanisms, workflows, but also data flows. And so we'll get into that in a little bit too. Then kind of understanding the value you guys provide. And it's very significant. You are leading to reduced ER visits. You're cleaning up helping streets be cleaner and for communities. And there is a financial sort of value you're providing to someone there. This is about quantifying that and proving that ROI or return on investment case to those stakeholders. And lastly, with that in hand, it's what's the contract path to actually get in conversations with hospitals, health insurers, state Medicaid to actually negotiate a contract here. The goals is to stop this disconnect between what you guys do and the healthcare system. So it's building the capabilities to integrate with healthcare workflows, referrals, tracking outcomes, leveraging data to show the work that's actually being done and what's occurring from an ROI standpoint. And then, secondarily, once that's possible, it's the contract value that's possible. And what we've seen is things like 400 to 600, even upwards of 800 in one of our Kentucky markets of per person per month fees on top of what you already have to work with these folks to get them housed, provide the right services across food, transportation, housing case management, job training, whatever it might be. Um, and so that's sort of in the housing first model of things. There's also from the hospital angle, medical respite models and getting hospitals to actually pay for out of hospital beds that then free up their own hospital beds for other patients. So diving into the first step here. So maybe you all are familiar with your healthcare landscape and the hospitals that are nearby, the safety net hospitals, the large academic centers, they all have priority areas around homelessness or social determinants or health equity. So it's understanding like what their burdens are, what their priority areas are, what are Medicaid priorities coming up in things like RFPs or requests for proposals, upcoming 1115 waivers or waivers that allow Medicaid dollars to be spent for non-clinical services like housing navigation, sustaining and tenancy services. Hospitals publish their community benefit spend or how they spend their non-taxed, nonprofit dollars that are supposed to be helping the community in sort of investable ways. But oftentimes it's their Medicaid shortfall or charity care that they're writing off for homelessness care in their hospitals. But it's also a signal as to what hospitals might be looking for in terms of how do they offload some of their ERs from boarding or housing patients for a number of days because there is no discharge plan or place to discharge them to. Um, and ultimately, what are the specific gaps that if you can identify and pinpoint across these reports, RFPs, waivers, state priorities, and then understand how you and your services fill those gaps. I mean, we've already heard a couple ways that they definitely do, but it's really pinpointing your value proposition of how you fill these identified gaps and making that case. So the groups that you can think about again, Medicaid managed care organizations, or MCOs for short. Other risk-bearing Medicaid agencies, sometimes there's MCOs sub out their risk or management of members to third-party organizations. Um, City Block, for instance, I guess is maybe a more common one you might have heard of. And then there's the nonprofit safety hospitals, of course, and then cities and counties, of course, as well. We've had interesting traction sometimes with cities actually just looking to not just address but solve homelessness as well. So kind of stakeholders across the board here, just understanding their priorities is super important. Two, so I think the interesting part here is you guys have, or I assume, and please correct me if I'm wrong in the chat or anything, I assume there are a lot of continuums of care under HUD here, housing service providers, and maybe, yeah,
There are
please.
four, which is weird from the East Coast. The majority of our folks are in what's called a balance of state that have sub-regionals, but it's technically one. So just to answer that question in real time.
Got it. Super cool. Thank you. Yeah, so the point is that there's the subsidy from HUD that you guys control or have access to is a resource for healthcare. How do you show that, align it? The services that you provide possibly paid for by HUD via some of the subsidies, is a resource for healthcare. How do you align those as well? What we've seen is, as the vouchers become available, either tenant or project based. I know project based is becoming more and more limited. Um, these are dollars that we've historically braided with Medicaid spend money, again, that 400 to 600 per person per month dollars. And now we have like a much bigger pot of dollars to run housing first models with high need clients. We're also exploring ways to say, okay, we have about 1,800 to $2,000 per person per unit here to house and stabilize someone. How do we capitalize those dollars or fund match those dollars such that we can actually acquire or ground up develop housing less on the development side because that's super cost intensive, though there are some models around that, but acquisition entirely possible, just given that there is a sort of guaranteed, as much as it can be guaranteed spend per unit for a period of time. Secondly, the partner organizations, this isn't your guys' job alone. And as we've heard, it takes teams of folks and different organizations that do different things. All of you are part of this health value chain or health driving value chain. How do you identify these organizations, partner with them, create workflows? And maybe it's the food pantry, maybe it's the local integrated behavioral health provider. It's all things that we can refer to as needed as resources are identified. And lastly, gets a little complicated here, but healthcare is such a barrier to entry because of its sort of protected health information, HIPAA, all things you might have heard about around patient data and patient security, all super important, but as long as you have the right consents in place, the right trainings for staff, the right sort of multi-factor authentication for any systems you log into, it's all possible to start accepting healthcare referrals and starting to leverage some of the data across IT systems like health information exchanges, admission discharge transfer fees, um, EMRs if you have access to our electronic medical records, and all of that helps to not only manage the clients and their needs from a clinical or physical health, behavioral health, and social needs standpoint, but also helps to demonstrate the outcomes that you're able to demonstrate and prove with the services you provide. So, thirdly, after kind of doing all those prelim steps, understanding the healthcare ecosystem, the services you provide, it's starting to aggregate and quantify the value of it. And this is dollars and cents for the most part. There is some strategic value as well, but it's really quantifying if you help some number of clients per year that yield some level of cost savings per year. And there's information online. We're happy to help you put that together. It's all available at this point. We've seen housing first services, and this is redemonstrated in the literature as well, has saved healthcare about 40+% per year, 42%. We've shown 50% cost of care savings in our West Virginia pilot a couple of years back. But this is the sort of value proposition and quantification and language that health insurers speak, hospitals speak, to start to put in somewhat of a financial model or pro forma. This is an example one we built for one of our housing providers down in Louisiana. But it starts to get into the level of sophistication and really starts to serve as a negotiation basis when you approach hospitals and health insurers or payers as to the value they would see from a cost saving standpoint, and therefore they should pay some amount of dollars to support the work that you're providing. And lastly, this is possibly the more convoluted and less straightforward path here, but it's really identifying who in these organizations, these healthcare stakeholder organizations, cares about this, is looking to address the social determinants of health. Is there health equity or pop health, population health person or community lead? I mean, there's a bunch of different titles you'd have to look for, but a lot of organizations, especially in healthcare, have them these days. They are your champions. They're the ones you need to win over and start to present again in a social, strategic, and financially minded way as to why they should work with you and why they should go down a path of either piloting, which carries a lot less, or if it's a grant-based pilot, a lot less restrictions in terms of like needing to show IT security and HIPAA or compliance and all that. So that's a great option. But if you get to the operational contract level, still great and possibly even a bigger contract that's possible. That's where a little bit more of the compliances and things will have to come in. And then as these contract negotiations get more down the road, that's where you start to actually map out what do you need from an infrastructure standpoint. Is it a new IT system to supplement the HMIS? Is it HIPAA attestation to make sure that you can check the boxes on security and again, staff training to make sure. So don't invest in that until there's more of a contract coming up imminently. We definitely don't recommend folks do that way before they start these conversations. Um, Easier said than done, but then, sign the contract and get started. So, um, not to dull this down, it's probably a lot more complicated at times and also could be a lot faster if you get the right person interested at the right time when they're trying to be competitive to a Medicaid RFP, for instance. So there's those windows that are really important to take advantage of when you see them. We've done this again across a number of states. We've driven about $2 million of healthcare and healthcare dollars and contracts into community organizations for this work. We've showed cost of care savings, ED utilization reductions of about 83%. Um, and we're kicking off a couple big contracts in West Virginia, Kentucky right now as well. But we're happy to help. This is the work we love to do. We love working with folks who are just trying to do the right thing for the right people. So thank you for having me, and happy to answer any questions with myself and my team here.
Yeah, no, thank you for joining us. I know we had a couple of folks who had to hop off at the top of the hour for conflicts. So I don't think we have any questions in the chat, although Rebecca, let me know if I'm wrong. But Samir, one thing I'm thinking about as we're working with about 60 organizations with this project. And um, I think folks, especially smaller nonprofits, are so used to talking about the work that they do. We're serving this many people, we're doing XYZ, whatever, whatever. Do you have an idea or a suggestion on how to approach those community champions? You had said, these are the folks in the hospital systems who are your community champions. How do you start that conversation? Like it's not just we're so great, we're wonderful. What's the strategic way and what's sort of that in for our folks who don't come from the healthcare system?
Yeah, and again, that's one of the hardest parts. I mean, it's just relationship building at the very, very base level. I think hospitals are, again, those champions at hospitals are hungry for folks like yourselves. I mean, not every, but a lot of EDs or emergency departments have social workers that work there. Maybe you already have relationships with them. And if you don't, please reach out and try to get those relationships started. And it's just telling your story. I think it's the right stakeholder, the right pitch to the right stakeholder. So obviously the social work would care more about the here's what we do and the impact that we have from like a social outcome standpoint. But as you work the way up the chain to then sort of the department head and then eventually the CFO or whoever might have to make those final decisions, that's where you kind of get more financial as you go. But yeah, it takes time. It takes relationship building. We've seen sales cycles take as long as, I don't know, 3 months to 18 months. Like it's no joke in healthcare. They're very stingy with money, but we're showing about 3x ROI here that's possible if everything's coordinated in the right way and healthcare ends up working with the right organizations, which again are not primary care doctors and things. It's you guys. So yeah, it just matter of making that case.
Um, Thank you. Any other questions? Any other folks have questions? Rebecca, anything come up in the chat while we were going through?
Not in the chat. Nope, not quite yet.
Great. Well, one question. Samir, are you okay if we share your contact information as we share out slides and stuff too? Okay.
Yes, please.
Okay. Danette's
Please do.
nodding along.
Folks can, yeah, reach out to us. Happy to chat, happy to help out. I know I blew through a lot of maybe complex information today, so happy to distill it down further.
No, it's super helpful, at least from where I'm sitting. So thank you for that. All right. Well, in the interest of time, I'm gonna move us along. Although, as people have questions in the chat, wait, I'm just kidding. I do see one chat that just came up. Let me check it. Oh,
All right,
never
that's
mind. That was your
fine.
email. Thank you. Thank you for that. Okay, I'm gonna stop talking and let Rebecca come off mute and launch our evaluation poll because I am terrible at Zoom, as anybody who was here before the meeting will know. So what you've got in front of you now is just a high level overview where we do this for all of our Zoom, excuse me, presentations as part of our Lift Academy. And I did just want to flag here, one, if you complete the poll, We are entered into a chance to win a gift card, a random drawing gift card. So please do that. We really love the data. We'd love to incorporate that into our future sessions. Going forward, we do have a few more coming up this month, one more coming up this month, and then a few in March. So next week, we're going to start looking at staff stability. So how do we reduce burnout, reduce turnover, keep folks in these very hard frontline roles for as long as possible? So we've got some experts coming from the nonprofit development center and a few others who are really implementing how do you do staff stability in nonprofits when wages are low, stress is high, etc. So join us for that. In March, we're also going to look at how to leverage treatment systems. So, sort of in the same way that emergency response has a lot of overlap with individuals experiencing homelessness, we see a lot with treatment as well. And that's not necessarily just, DUI or not DUI, excuse me, SUD treatment, but behavioral health sort of treatment in general. So, we've got a couple of experts who are in the treatment field who are also leveraging housing as a way to help provide treatment for people. And then at the end of March, we'll have another panel discussion around best practices in emergency shelter. And I believe we will primarily have some folks across Colorado who are doing that emergency shelter, although I think we're still finalizing that lineup. But Rebecca, you could probably answer that more clearly than me. In the meantime, we do have, as I've mentioned, all of our recordings, all of our sessions that have been done so far on our Lyft page. That QR code will take you right there, as well as the actual URL right there. And if you all haven't seen that, please take a look at it because we've been doing this content for about 9 months now, so all of our recordings are there. I'm gonna keep us moving. Rebecca, are we getting the poll responses that we need?
I show the poll is up, so hopefully folks can see
Okay.
it. I don't see responses yet, but I know it takes a few minutes for folks to.
Okay.
Oh, we got one in, so it must be working.
Okay, cool. All right. Well, I know we are a few minutes early, but I know a couple of other folks did have to hop off early for conflicts today. So I think today is just one of those days. So we're going to hang out here. We're going to leave our poll up. I might go ahead and stop the recording. I don't see any other questions coming in the chat. So if folks do need to hop off or, go on to other meetings, please feel free. Otherwise, we'll leave the poll up for a little bit while. Rebecca and I will hang out here in the meeting. But I think, unless any of the presenters who are still on have anything else that they want to share, I think we're going to let you all go a few minutes early today. Anything from Loaves and Fishes? I know Braulio had to hop off, but Loaves and Fishes or / anything else you want to share? Thanks, Dee Dee. Next time we'll just have you come on early, Dee Dee, and see if we can test your voice because I feel like you always want to come off mute in these presentations. Okay. All right. Well, thanks, folks. Thanks for the time. I think Rebecca ended the poll. I give up on Zoom today, y'all. Um, Thank you so much for the time. Thanks for the presentation. Thanks, Samir. It's nice to have you in this space. Rebecca and I will be here if you need anything. Otherwise, enjoy the rest of your Thursday, folks.
Thanks, everybody. And the poll is
Talk
still
soon.
up, so if you're mid-answer, keep going.
Perfect. Thank you, Rebecca.
Thank you guys very much.
Thank you so
Thank you,
much for being
guys.
here, Tim and Danette. We appreciate it.